Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
Knees. Do people have painful knees?
Painful total knees.
Do people really have painful knees?
Are we on the radio?
Yes, we are.
Oh, good morning, everyone. This is
Dr. William Leone, our favorite orthopedic surgeon.
You're very kind. Good morning, everyone. So we were just chatting. Do people have painful knees? And of course, and a lot of people ultimately have knee replacements, and it's a remarkably successful surgery for most, but not for all.
And I have to add to that, if they go to the right surgeon, and I know you wouldn't say that, but I have to say it because I have friends who are still limping after things, and I always say, why didn't you go to Dr. Leone? If you, my wonderful husband, and it's such a tribute to you because he was able to do, till the day he died at 93, for 25 years, he was able to function so beautifully because you were the doctor that kept his knee, especially his hips, done.
Yeah, exactly. So it truly helps people, and the number of people that are having their knees replaced is exponential. It's just a crazy number. Some calculate between 2005 and 2025 that the incidence has increased. Can you believe this? 650%.
No.
I mean, no, 650%. So it's exponential. And my generation, of course, doesn't want to hurt. They're not going to tolerate it. So there's a lot more total knees being done. And when we ask patients how they're doing, the vast majority do really well. About 70 or 80% are doing great. But then, different than hip replacements, where a much higher percent do well, there's still 20 to 30% when we ask them, when they're administered these patient-reported outcome measures, these standardized, statistically validated measures, they're not satisfied or they're unhappy. So, and then you have to go. So, while the doctors may look at their X-rays and they may watch them walk and they may measure their angles and all this and that, that doesn't really matter if the person who has it is saying, but it still doesn't feel comfortable, or I still can't trust it coming downstairs, or it still feels like there's a band-like tightness around my knee. And so what we see is that a very large percentage of these people, it's kind of hard to figure out why they're not doing well.
So why aren't they?
They typically go from one doctor to the other doctor to the other doctor, and everyone does the same thing. They talk to them and they examine their knee, and it moves pretty good, and they look at their X-rays and they say, it looks really good, but of course the patient is still stuck with it feeling bad. So we actually call them the looks good, feels bad patients. And it turns out that because there's such a very important and very complex system of balancing the knee, of this soft tissue sleeve that surrounds the knee, and if it's not balanced, then they're not comfortable. So if we think about a knee, we think about this big old hinge joint. But the reality, it's a lot more than a hinge joint. It's a hinge joint that pivots. And so as the knee flexes and extends, it's actually pivoting on the inner part of the knee, the medial compartment. And so as it flexes, the femur, the back of the femur on the outside actually falls off the tibia. So the tibia internally rotates. And as you extend the knee, it goes in the other direction. The femur goes back on the tibia, and the tibia externally rotates. And we call that complex mechanism a screw-home mechanism. And that's part of how knees work. But think of the soft tissues that have evolved from beginning of time, and certainly within us, they've evolved to maintain that very complex movement. And so when we go into these knees that are arthritic, there's no cartilage, the bones are rubbing, and we replace the ends of the bones, we resurface them, if you will. If we don't also recreate just the right balance on this very complex soft tissue sleeve, then they're many times not comfortable. And so we've known this for a long, long time, and we have these methods of trying to do that, but they've been crude methods. They've relied on eyeballing it and looking at it and our experience and feeling it and moving it back and forth and examining the knee. and it's pretty good about 70 or 80% of the time, but it's not as good as it could be. It certainly isn't 95 or 100% of the time. And so new technology has really come along that we've been using on the primary side, which truly has moved the needle. You know, a lot of things are always coming out that sound great, and quite possibly they're sexy and they're wonderful for marketing, and you can talk about them, and the robot and the laser and all this stuff that just sounds awesome, space age. But does it actually make people feel better? Does it actually improve their perception of how they're doing? Many times the answer is no. They're just cool, and they add a complexity, and maybe there's a little niche for it. But some things really do move the needle, really make it better. And this, in my experience, has truly made it better on the primary side, such that when someone comes back now at 6 weeks after a total knee, if they're not doing absolutely as well as my total hip, I'm like, wow, what's going on? That's really surprising. Well, before, you know, me, like everyone else, it's still a percent just aren't going to do as well. So now if you take that instrument that we're using on the primary side, and someone comes in with a painful total knee, they've already had it, they're not happy, no one can figure it out, and so now I'm able to put that device into their already replaced knee, and now it generates data that I can kind of analyze why their knee is painful. It's too tight here, it's mal-rotated here. So in a super elegant way, I've been able to just often do very minimal surgery.
So you're tweaking it.
Well, I can go in, and rather than go in with the mentality which we typically have of, okay, someone really isn't happy with their knee, let me just change their whole total knee. So it moves it from a let me change everything mentality to let's now be scientific and get more quantitatable data and pinpoint where the problem is, and then hopefully just be able to do something minimal and release this and maybe change the plastic or only change the tibial component because it's too internal or too externally rotated, and that twists that complex soft tissue sleeve so it's not comfortable. And I must say, these have been some of the most gratifying patients coming back for me, because, you know, you kind of smile and you say, wow, I really solved this in such a neat, elegant way. So I'm now, so I've done about 22, 23. I showed my data with 5 or 6 other centers, and we published it. And it, you know, nowadays everything is about saving money, but it really demonstrated that because we use this technology in a very high percentage of these people where we went in thinking we would change everything, we only did a partial revision, just changing the plastic or just changing the plastic and the tibia. You know, it saved the system a lot of money, but more than that, people did well. So now I'm excited that we're finally, okay, we're going to do this now in a prospective fashion. We've created a study, and we've got an IRB approval, and we're going to start just launching it. So my next 25 or 30 or 50, I'll really be able to really hopefully bring to the medical community some data that helps people. Because there's an awful lot of people that are getting their knees done, and of that, there's unfortunately a significant percent that after their knees are done, they still don't feel satisfied. And how can we improve that?
I'm going to then ask you formally to clear your calendar for May the 6th. You need to come to Cure and talk about this. Okay. So you got to really, because this sounds like something new and wonderful, because there are a lot of people walking around with so-so knees after it was done. They've gotten used to it. They can't bear to think to go through another whole knee operation. And it sounds like you've now come up with something pretty exciting.
Well, it's hopefully going to be one more solution that if you can really define the problem, then you can address the problem and fix. I mean, these total joints do exceptionally well when certain things happen right. You know, it was done for the right reasons. You get the soft tissues right. The components are moving against each other in the right fashion and the right orientation. People do super well. But each of those variables, of course, is a variable, and it's hard to get that consistently if you're the surgeon. And
one thing that we were talking about with Dr. Mancia, where they put bone in when they're trying to do implants, you did bone with Bill. I remember that. He had to be off this was on his hips. that you actually brought in a lot of cadaver bone, I think, to build that up.
So, so what happens frequently when an old joint, a joint that's been in there, a prosthetic joint that's been in there for a long time fails, is it wears, the bearing surface wears, and typically it's the plastic that wears because that's the weak link, or the interface between the plastic and the metal that holds it starts moving, and in the end result is that it creates little particles of plastic, very, very tiny particles, micron size, so small that the cells can recognize it as foreign and it can eat the plastic, phagocytize the plastic. Well, of course, they can't digest plastic, and so it creates them to burst. And before you know, we have this inflammatory process in this artificial joint, and that can turn on these mechanisms, turn on the cells in our bone, the osteoclasts, to start destroying bone. So the end result is not only is it inflamed, but the bone that then supports the prosthesis then becomes destroyed. So before you know, we have this prosthesis getting loose because the bone that supports it isn't doing its job. It's being eaten away. And so then when we go back into these people that need to have their hip or their knee revised or redone, we of course take all the old stuff out and we look at what we have to work with, and oftentimes it's like an ice cream cone, but there's just a big open shell and there's nothing in the middle of it. And they say, well, goodness gracious, what are we going to do with this? And so one of the remarkable cool things with what I get to do is if you have a cavitary defect, a defect in the bone, or even a segmental defect, there's just no walls or anything, you can potentially reconstitute the skeleton. You can rebuild the bone by taking bone from one part of the body and putting it into that area, and if it's under compression, it's the right position, and blood vessels can grow into it. With time, through a process of creeping substitution, the blood vessels grow into it, it removes the dead bone, it starts laying down new bone, and it actually regrows bone. So you can use bone from someone's own body, called an autograft. That's, of course, the best because you can't catch anything, and there's no rejection, or you can use bone from someone else who's either had a hip replacement or they died and they've been checked and tested and whatnot. And that works well too. And that's called an allograft. But it's interesting. In today's world, I very seldom now use allograft like we used to. Like everything else, it's evolved. There's been what's taken is I often use bone from the preparation of the prosthesis, more commonly on the hip side, preparing the socket. It creates some bone graft, it looks like ground hamburger meat, and you can pack that in the small defects. It works beautifully. But if there's really a big defect that's also structural, what's been developed now are these wedges and different shaped cages and buttresses that are made out of metals that are very open and porous, kind of like on a coral reef, and it really matches the structure of bone. If you were to get rid of the calcium and phosphate, what's left, and so those are structurally strong, and bone can grow into them, and that's pretty much supplanted us using a lot of structural allografts like we used to.
Well, Dr. Leone, you do a lot of planning. I can see each person is like a puzzle to you, and you make sure. And before you answer that, give me a phone number that people can call you, please.
That is 954-489-4575. And, I'm very blessed. I've been at Holy Cross now. I'm starting my 27th year of practice, so you have to just smile when you say that because you remember when you were the brand new guy and everyone looked at you.
Yeah.
And now you're the old guy and everyone asks you.
Yeah, right.
But
So
I've been given my own, orthopedics at Holy Cross is really...
you're their star. I understand that.
There's a lot of really wonderful people.
But, I know you can say that, but I know from so much experience, and I really do recommend you. I always recommend you. And people always walk around looking, well, tell me who I should go to, and then they try 2 or 3 other people. But I have to just say that I have recommended you, and unfortunately some people, whom I won't mention, decided to do something else for whatever reason, and they're unhappy. And I always say to them, I put my finger, I said, I told you should go to Dr. Leone.
Everyone has to listen to their own heart, but I think there's a lot of marketing, and I think there's a lot of false emphasis, particularly in South Florida, a lot of fluff, and what you see is not what you actually get. And I think at the end of the day, this is still very much a people game, and it's very personal. And I think it's not about which particular technique I use or which particular prosthetic I'm going to put in, or it's truly about if you're the consumer, if it's now you or someone in your family, it's truly about finding the individual. It's about the surgeon.
Right.
That's everything else is very important, but it's truly secondary.
Yeah, well, you're such a dedicated person too. I mean, this is the one thing about Dr. Leone, that he everybody becomes his friend. All his patients are his friends, and he really cares. And I've had so much experience with you in so many ways, and so I couldn't recommend you more highly. So it's William A. Leone, and the phone number again is 954-489-4575. It's called the Leone Center for Orthopedic Care. So in this new new study that you're doing, you said 25 successful?
Well, no, it's based on about a 3.5 year experience. I started using this kinematic sensor. So it's an insert. Normally when you do a total knee, you've got your femoral component, the cap on the femur, the tibial component, the metal tray that sits on top of the tibia, and between those pieces of metal is plastic. And of course, we keep improving the shape of it and how it secures to the tibial component and the quality of the plastics, but it doesn't negate that the tissues that control the knee have to be balanced. So now imagine a trial, so we don't actually leave it in the body, we just use it to get things right, a trial insert that's exactly shaped like the one that we're ultimately going to put in. But this one is special because this one has a microcomputer chip and some pressure sensors on both sides. So now using wireless technology, it measures in a super, super accurate way what the loads are, what the pound of pressure is, so what the tension and the ligaments are on the inside and the outside. And it shows where on the compartment it's loading. So now as we move the knee through a range of motion, we actually have a kinematic signature. We have a movement signature. We can see, is it pivoting on the medial compartment and moving on the lateral compartment like we expect it to? Or is something too tight and everything's being pulled laterally? Or is it aberrant and it's going anteriorly instead of posteriorly? So all of a sudden, we have data. We have a clear, there it is, visual image of and quantitative image of what's going on. And then we can say, okay, if we do this, if we release this, if we take a little more of this, then we can improve the motion signature and we can more closely balance within 15 pounds the pressure throughout the range of motion. And it's just been, it's truly made a difference. Some things are cool. This takes a lot longer, but it just makes a difference.
So after you've seen that, then you go in and you do this partial revision based on your results.
So with that insight and that knowledge and that experience and several hundred people doing it with first-time knees, a lot of people will come back who've had a knee that aren't doing well and they look good. And you say, well, I think it's because maybe it's too loose on the inside or too loose on the outside or some people, or it's too tight. Maybe the PCL is too tight or maybe the tibia is mal-rotated. So now if it's one of the varieties from several companies, which is huge companies, that I can get this exact matching sensor, then I can put in the trial and I can range their knee. And now we have quantitatable data to say, well, that's why they're not doing well. Look, when I bring them out an extension, it's way too tight medially. Then it's too so it's the posterior aspect of the medial collateral that I need to release a little bit. And you go back and you release it, or you look at how, in extension, how the components are relating to each other. And you go, oh, look at that. The tibia is 12 or 15 degrees internally rotated relative to the femur. I just need to change the tibia. And so you take the tibia off and you put it on in a neutral rotation, because now you're not guessing, you're actually having quantitative information. And, without this data, if somebody actually comes to you and they trust you and you're going to be the one trying to solve their problem and you're going to be revising their knee, you really want to get it right. And are you just going to only release a little tissue and trust yourself? So, again, the human nature is, well, let me just fall back on just redoing it. Let me go back to the system that I'm comfortable with. Let me take this one out. I don't really use it. Let me put in mine. But typically when you do that, you always lose bone. It's a lot more surgery. You have to go up a degree of constraint. So constraint, of course, is how things lock together. And if things don't lock together very tightly at all, there's less stresses on the interfaces, on the interfaces between the prosthetic and bone. There's less tendency to shake it loose. If things are really constrained, like a hinge knee, well, then there's a lot of stresses on those interfaces, and there's lots of gradations in between. But the typical mentality and the typical teaching, and it's correct, is that when you do a revision, you often go up one or two notches of constraint. You may move from a posterior cruciate retaining to one that has a more constrained tibial insert, or maybe a posterior cruciate substituting, or even a much bigger post that even gives you stability medially and laterally. So there's different, but now are you going to really have the confidence to just put in the same, not go up a notch, so you're not burning bridges for the future and you're solving it in a much more satisfactory way?
So let me tell you, as a person talking to people in the public, they'll say, well, I had my knee done. I said, well, how is it? Well, it's not perfect. And you see them kind of limping a little. But look, I've learned to live with it. And it is what it is. So now what I have to say to people is, no, it doesn't have to be that way. There is now a way for your knee to be re-inspected. And that's a good word, re-inspected. And you'll be able to maybe walk and not say it hurts, or not say I can't walk very far, because I know people like this. This is a great show today because
I think
you're introducing something that we have not heard about.
No, this is new. If we all have these cars now, which we can't work on because they're all electronic, right. and you take your car to the mechanic, any mechanic in a little tiny town anywhere, and the mechanic plugs it into a computer, and the computer does this very sophisticated analysis of all the systems and tries to say, oh, there's your problem. It's
right.
the X, Y, or Z. Well,
right.
Now, for the first time, I think we can say, well, rather than your knee hurts, it looks good. We proved it's not infected. I don't think it's loose. Let's try to plug it in the computer and see if there's something that can be, what is wrong with it and what we can do to fix it. Because if you only fix the part that's wrong, it's a lot quicker recovery. It's much, much more satisfactory.
This is a wonderful thing that you've just come up with. And so what do we call this? Again, you said it was something, and what was your word?
It's a kinematic sensor.
Kinematic sensor.
It's also called. It's actually the brand is actually Ortho Center, and it's being developed here, and it's now
Ortho Center.
Yeah, it's going worldwide, and it's really cool, remarkable technology that I think has really changed. It will,
But you were given the opportunity, because I guess of your experience and all, to be one of the people who tested it out.
Yeah, we've been a beta site.
You're always so humble. I just have to get to say these
very
things.
Kind.
No. So you were one, and now will you be teaching other people how to use it?
Well, we've published this paper. It's retrospective, so it's not nearly as powerful as really doing a truly controlled, internal review board controlled prospective study with many centers. So that's where we're at now. I'm just going to start, getting patients, offering it to people if they want to enroll, letting their doctors know that there's something for your patient that keeps coming in and saying, I've got this band-like pain,
exactly.
or it just doesn't move, or it feels wobbly, or I can't trust it. And so maybe there's someone that could be helped with that.
Oh, I'm sure there are plenty of people because I've spoken to them. So that's great. Now, and we only have probably a minute or two, and you won't have, just you can answer very quickly. Are you having the same success with hips that were not done correctly?
I've truly built my career on not just revising knees, but really a lot more hips of people that have had problems that now who's going to fix it?
So you're it.
So I've been a
Yeah, you have been.
safe haven where no one gets in trouble, and we just fix it and we figure it out. So that's been my passion for my whole career.
Right, because you did invent the wonderful.
You're very kind.
Well, we know because you've shown it at our Cure Symposiums that it's a carpenter's tool. What is it, the leveler?
There's so many super sophisticated ways to do it, but sometimes you have to say, well, what are the assumptions you have to make, and how can I narrow those assumptions, and how can I make this more accurate, more predictable by measuring and not guessing? And again, it's what really moves not just is great marketing, but what actually makes people better.
So this is a strange question, but are your professors or the medical professors who you had still around? Because if they are, they must be very proud of you.
I'm actually invited to give a grand rounds at Miami.
See, I just knew it was the right question.
Yeah.
Right? Because you've proven something. You were a young doctor, went in there, and you did something, and you took it really very, very much to heart, and you were going to do the best you could.
I think if you're passionate about something,
Yep.
and I think if you stay with, I've been in one practice. I've been at Holy Cross my whole career, which is remarkable. Everyone moves around. And I focused on one thing, which is just hips and knees for my whole career.
Amazing.
And I really get up in the morning and think of things and keep making it better and keep making my whole practice has been reinvented. I don't want to just see how many I can do in a day. I really want it to be a great experience.
And it has
I have
been.
a different team. I have a different approach. It's a whole different thing.
Okay, well, I want to give the phone number. If you like what you've heard this morning, call him at 954-489-4575, 954-489-4575. His name is William Leone. Thank you, Dr. Leone.
I would really encourage people to go to my website because
Okay.
I put so much energy on it.
Okay.
I've written so many articles that people respond from all over the world. It's amazing. I get almost 15.
We are out of time.
Okay.
Tell me what the website is.
It's on that card.
Oh, I'm sorry. I'm going to do it real fast. It's holycrossleonecenter.com. holycrossleonecenter.com. Thank you, Doctor. Really appreciate it, Dr. Leone.